This video will discuss the prosthetic conversion of chrome guided smile. This particular case will be an upper and lower same-day chrome surgery. And the focus of today will be some pearls and some tricks and tips about the conversion of the prosthetic. We'll quickly go through the surgical aspect of the case. The doctor was kind enough to share some photos of the surgery and of the surgery mat. This upper surgery mat is for the upper arch and the lower is for the lower arch. And this is taped to the wall and gives guidance on the angles of the implants, the position within the bone, how the chrome looks in the mouth visually. So you can at a glance look at the cabinet and then look back down the mouth and see if things seem to be going properly. And then on the right hand side, this is for the upper surgery, and this is the mat that sits on the countertop with the implants all placed in their position, the MUAs by angle and size, and then all the temporary cylinders are also placed on here. So it's nice and organized for the surgery. So as with all chrome guided smile surgeries, the pin guide is tried in and then removed, and then a labial reflection is performed. And then the pin guide is reinserted with the fixation base attached. So you can see pin guide, fixation base is in, and then of course the pinning procedure, which is discussed in much more detail in other videos. One important thing is to know that the pin guide has windows to ensure that there is full seating on the occlusion. So you can see that there's contact with the occlusion. Then you know the pin guide is down, which is critical to having the fixation base positioned in the exact proper position so that all the subsequent components are in the perfect position as well. Then the carrier guide can be placed in order to ensure that there's enough bone reduction as just kind of a test. If it's passive, if it seats, then it can be removed and move on to the osteotomy. Otherwise, reflect more tissue, adjust more bone until it's passive. Then the bone is tested with a finger. You can take your finger passively from the fixation base to the bone and make sure that there are no burrs, any bone spines, anything at all that would hold up the carrier guide or any other prosthetic or be sharp areas against the tissue. So this is all very smooth and reduced. Then the osteotomy guide is inserted, and the doctor goes through the sequencing of making osteotomies and placing implants. As you can see here on this case, these are 1, 2, 3, 4, 5 angled implants. It's a little bit of a trickier case, but the little nubs here, 1, 2, 3, 4, the little nubs on the osteotomy guide control the rotation of the implants and give indication of rotation so that the temporary cylinders are straight. Very important. This doctor used a pretty unique suction device for aerosols. And then again during the surgery, just glance up at the surgery mat on the wall to confirm implant positions, etc. So once the implants are all in, then the temporary cylinders can be added. And one of the nice tricks with chrome is that you can seat the prosthetic and you can close the patient down to test a bite. And then you can also, of course, test the passivity of the prosthetic over the temporary cylinders. But at this point you can check the bite. And just to show the accuracy of the guide, you can see the workup, the STL workup from the export from the software shows, this one implant here, number 8, is a little bit tilted. The others are all straight, and really a nice job of placing implants in their proper position. And if this part is accomplished perfectly, then obviously this part will be perfect as well, in that the temporary cylinders will be found located in the middle of the holes in the prosthetic, and it'll be passive, and it'll have a very simple prosthetic pickup. So as with all cases, you'll place the blue gaskets. They used to be green, now they're blue gaskets, and that will block out the MUAs. And then the temp cylinders have blue plugs placed in them to block them out, and the prosthetic is seated. And then the doctor would just simply go through the process of luting the temp cylinders to the prosthetic by backfilling between the two in the voids. So in other words, filling all of these voids so that the prosthetic connects to the temp cylinders. So this was a pretty straightforward surgery, but let's talk about the prosthetic conversion. When there are divergent implants, sometimes there are still parallel temp cylinders because of angled abutments. But sometimes there are also all straight implants, but then the temp cylinders are still divergent, which can pose a problem for the prosthetics. Now, why are they divergent? Because the implant could only be placed in a certain range or certain position, and it could not be such that these are perfectly parallel, the temp cylinders. So what you'll find is that during the restorative, during the conversion, that a temp cylinder or two will be very close or almost touching the prosthetic when you're trying to insert the prosthetic. And so if they're divergent, like this number 8, or sometimes even more drastically divergent, it's okay. It was planned that way. And what you will do instead is seat the temporary cylinders that are parallel, and then seat the prosthetic, and then leave, in this instance, maybe number 8, perhaps number 9 out. And then once the prosthetic is seated, then drop the temporary cylinders down from the occlusal. Because the holes on the prosthetic, the holes on these prosthetics were designed for the temporary cylinders. The hole is the same trajectory as a temporary cylinder. So therefore, from the occlusal view, you'll notice that the channel in the prosthetic follows the temporary cylinder channel. And therefore, from an occlusal drop, from an occlusal seating, the temporary cylinders really should drop in nicely. So that's one tip, occlusal dropping. Another, before surgery ever starts, it's very important to order multi-unit abutments with the proper collar height. If you're placing a deep implant, then you may want a collar height that's 2.5, maybe even 3.5. It's rare that they're that tall, but with some systems you don't have a choice. Nobel only has a 3.5 collar height on their 30-degree implant, where Neodent has a 2.5, and I believe they even have a 1.5 on their angled 30-degree angle MUA abutment. Now that's critical because the lower the collar on the MUA, the lower the temporary cylinder. The temporary cylinder will be protruding from the prosthetic, and this is a good thing. You want this to protrude a little bit. If it's buried, like this one and this one a little bit, what that means is that the collar of the MUA may be exposed in the mouth. It's too tall, it's above the tissue. And you really want the collar of the MUA at or below the tissue so that it doesn't show, so that you don't have to hide the abutment with the prosthetic. Too often we make flanges and we make concavities on these prosthetics because they're covering components. And really the main goal of this is to seat a prosthetic that just blends into the oral environment, that the prosthetic and the tissue have a nice relationship, and we're not trying to mask anything. So you can see here, these temp cylinders, they probably are in pretty good position, except perhaps number 9 here. So most of the time, we recommend ordering 2.5 or lower multi-unit abutment collar heights on every case. And then you won't have to worry about swapping them out later because they're super gingival. When the prosthetics are removed from the mouth and converted, as you can see here, these are pre-conversion. Conversion. They've been converted, but this is pre-finishing, post-finishing, post-finishing. And you can see here on the intaglio, the lab tech or the doctor or the assistant fills these voids with, in this case it's stellar material, but lots of materials work. We recommend stellar because it's a dual cure, and it also comes in white, which is nice for the occlusal. But the doctor will fill the holes and also fill the little voids around the temporary cylinders to completely attach the temporary cylinder to the prosthetic. You want to ensure that this is clean, it's not wet, it's not contaminated, because these are obviously going to be in the mouth for months. So backfill each. You can choose if you want to use pink or white You can see this is a lab technician that we send out on the road, Rick, who likes to use white and pink. It's kind of nice. In the pink area, where the gingival is, it's pink, and then in the occlusal area, it's white. Usually it's almost a bleach shade. It's kind of a higher Vita shade color. And then what the lab tech will do is just kind of refine this and flatten it down and adjust it down to the occlusion, and then when this is delivered to the mouth, it's equilibrated. So that's the conversion of the prosthetic. There's also the conversion of the rapid appliance. And with the rapid appliance, you perform the same type of pickup, but then it's not really critical that this is all refined and trimmed unless you're going to take a bite at this point. But normally, this is just a pickup, and then you use the rapid appliance in several months or a few months when you're going to convert to final. But you can see here that the technician did backfill around each cylinder and really finished it up nicely. And you can see on this also that the temp cylinders for some reason seem to be a little bit higher. Now perhaps the technician adjusted the intaglio of this, is what it looks like. It has a little bit of roly-poly here, probably making room for the wash impression down the road. In fact, I'm sure that's the trick that he used. So he just ground this back a little bit. We could probably do this in the laboratory before we ship it, but you could do it manually, and then you'd put tray adhesive on here and then do a reline impression when you're doing the bite and occlusion down the road. So that's the rapid appliance pickup and the prosthetic pickup. And that was for the maxilla. On the mandible, something different happened. The case was planned for 6 implants, but the distal 2 were not delivered. And that's okay. Chrome still works. In this case, the doctor would just pick up the 4 temporary cylinders on the prosthetic that the patient's going to wear home, and they'll do something a little bit different on the rapid. But on the prosthetic, you can see we designed this for 6 implants, right? But only 4 were delivered, and so the technician and the doctor just simply trimmed away the cantilever, right? So just between these 2 implants, trimmed it away, because you really do not want to leave any cantilever on an immediate load. Perhaps a bicuspid, perhaps half a molar, but no more than, say, 6, 7, 8 millimeters of distal extension beyond the middle of the implant. Perhaps 10, but it would be from the middle of the implant, not from the edge of the temporary cylinder. Middle of the implant, go back. That's the extent of your cantilever. So just a couple of different views here. The pickup is very similar on the upper as the lower. Maybe he ran out of pink here and just used white, but converted it, took it back into the laboratory. And then you can see here the temporary cylinders are a little bit lower in the prosthetic. So then maybe there was thicker tissue on the lower, or perhaps the doctor just used a lower collar height on the temporary cylinders. But did a very nice job of converting. Looks like this technician takes some glaze along as well to reglaze it after it's been converted. Really give it a nice shiny look. Now here's the pearl. The doctor had enough torque on those 2 distal implants that he was comfortable placing multi-unit abutments and picking up the temporary cylinders in the rapid appliance. Now think about how much easier this is down the road now that all 6 implants are picked up. Obviously these are not going to be loaded because the surgical prosthetic, the take-home prosthetic, only has those 4 picked up. But in the rapid, pick up all 6. If you have time, if you have the parts, and if the patient has the patience to do it, pick up all 6. Another pearl would be, at a minimum, pick up 3 if you're in a hurry. Pick up 1, 2, 3, and then they're indexed. Then this is indexed to the implants, and you could pick up this one, and this one later. 3, 4 months down the road, just place temp cylinders on the multi-unit abutments and pick these up down the road. At least you have it tripoded and indexed to the patient. Otherwise, it's a floating process, or it's abandoning the rapid altogether. So this was a really nice thing that the doctor was able to do. I'm presuming it's only because there was enough torque on these distal implants to feel comfortable to screw down MUAs. That's a nice trick. And then, as I mentioned, this is upper and lower. Some nice final pictures. And as you can see, this is a pretty normal appearance on the lower. This is not really a high water design. Could be, I suppose, a little different angle. You might see a little bit of a gap, but that's nice. And on the upper, it's a nice seating to the tissue. Really nice work on this case. So thank you for watching this video on tips about converting prosthetics.